Doctor, that seems where we are all stuck right now. And so what did we do? We went out and got the doctor. Dr. Mark Baldwin is out at Pacific Northwest University Health Sciences. He joins us this morning. He is the Department of Internal Medicine chairman out there. Good morning, doctor. How are you?
Good morning, gentlemen. I hope everyone's okay.
We do too, Doc. We do too. Thank you for your time this morning. We appreciate it.
No problem.
Where do you hail from originally?
Originally from Illinois. I went to medical school in Kansas City and then did all my training in Chicago. So been out in the Northwest for about 6 years and in Yakima for almost 2 years. So we love the Northwest. So
excellent. It isn't as though your home turf isn't getting pummeled like we are here too. Chicago's
that's
getting it
right.
as well. So in your studies of internal medicine and what you, you talk about having a teachable moment for your students. They don't come along like this very often. What are the lessons that you think the medical community has learned from all of this and society as well?
Well, I think the biggest thing is that infectious diseases still are stronger than human beings. We, as physicians, sometimes we get lulled into becoming victims of our own success, and every now and then we need a wake-up call that, we're still learning about disease, about health, and, those kind of things.
Yeah, it's the smallest, tiniest among us that could bring us down. I have a very vivid image in my mind of when the War of the Worlds played. I wasn't there then, but subsequent studies.
Neither was I, for that matter.
Good to know, Doc. Knowing that it was the bacteria that took down these, uber intelligent invaders, that all this technology and everything all brought low by the smallest of organisms. One of the things that we keep hearing is about our nation's hospital capacity, and will this break the system? Put that in regular terms for folks. What are we talking about when we talk about a system that could break?
Well, it's all dependent upon how effective the quarantine measures are and how closely people follow them. This type of virus, like a lot of upper respiratory tract viruses, is spread by people-to-people contact. For example, somebody could be walking down a hall who has an acute coronavirus infection, cough several times, not cover their face. An hour later, somebody else could walk through, and the virus particles can stay suspended in the air, and you can inhale it, and that's a way you can get contact to it. That's the scary thing. It's just because you can't see it, taste it, or feel it doesn't mean it's out there. It is still out there, and I think that we haven't had a good pandemic in the world for 102 years since the influenza pandemic. From that, we were able to learn that in the communities that did have shelter in place or either voluntary or enforced quarantine had a much lower infection rate. And that's, in medicine, that's kind of common sense, but sometimes people don't need to be reminded of this. Simple things, covering your face, washing your hands, avoiding close contact, that works better than anything else to prevent it.
So what we're doing now is what we should be doing.
That would be correct, yes.
My mindset is that think as though you've got it and everyone else is your grandma. Right?
Yeah.
That's true.
Yeah.
And I think you raise a good point because, this was, as this has evolved and is continuing to evolve, there was this idea that, yes, older people are at much higher risk of not only getting this, but also of dying it. But if you look at the statistics, and I can more than happy to share some of these websites with your station, that this is affecting young people, too.
Yeah.
Young people, younger than us, people in their 20s, 30s, 40s are getting this. Now, they may not be dying, but the story is yet to be written. I think that sometimes trying to interpret this is like looking at a string out of a tapestry and trying to figure out what the tapestry looks like.
Yeah,
we have to go back and look at what has worked in the past, and that has been keeping our distance.
One of our listeners, Dr. Craig Westbrook, asked this question. He says,
"Sure.
Does flatten the curve mean that the same number of people will get the virus anyway, just not all at once?"
That, I think right now it's too early to tell, but I think that we need to go back and, again, do what has worked in the past until we have data to prove other things. And that means keeping our distance. That means, avoiding contact and that. The study that I think that people are talking about in your earlier hour, you mentioned ripping off the Band-Aid quick or slowly. That is one model. I think that we can't really put a price on human lives. In China, where we have the most information, they had, as we know from the news, an ironclad quarantine policy, and it burned out after a couple months, and there have been no new reported cases. In Italy, they're under this now, and now I think it's, a lot of the regions in the United States are going to this. So I think we have to go with what's worked in the past.
Certainly weren't any kids in China headed to the beach for spring break, right? So
no,
yeah.
no.
When they dropped the hammer, it's dropped. And so I guess if 2020 hindsight, somebody said, hey, there's this virus thing coming over from China, stop all planes, and then everybody do what the governor ordered us to do yesterday and what the health district ordered us to do, and that is to stay home, keep our distance, and all of that. Had we done that, where might we be now if we'd have just totally jumped on board?
That's speculation,
Sure.
but I would imagine that our infection rate would have dropped considerably. But China or the Asian travel was just one part. We would have had to restrict it from all over the world.
Sure.
Because we're a global society now. We didn't have global traffic in 1918.
Well, at the same time, the regular flu is going on, right? This does not...
Right.
And so we're sustaining a number of people in hospital beds because of the regular flu. We're going to have a certain kind of death rate because of the regular flu. Trump, I think, yesterday said in his press conferences that we're on target for maybe 50,000 flu deaths. Does that sound right to you, Doctor?
We would have to wait. Something like that would probably be correct. However, the difference between the COVID-19 and the regular flu is, again, based on what we've seen in China and preliminary data from all over the world, this tends to have a higher mortality rate. And not just in older people, we're seeing this.
And not just in the older patient group, right?
Right. We're seeing this in, I'll give you an example. Right now I'm looking at the Yakima Health District report from yesterday evening that we have 41 cases here, as you've reported. 21 of those cases have been in people less than age 50. So that constitutes, half the cases are people that are younger than 50.
So I guess in layman's terms, does this thing have a lifespan? I mean, can we out quarantine this thing, or does it just go away? Help us kind of understand that. I mean,
sure.
Is it, yeah, go ahead.
Quarantine seems to be the most, and I think that most infectious disease and medical experts will tell you quarantine is right now the most effective tool that we have. Let it burn out. Where it's again, we have to go back and look at our experiences from China that with a strict quarantine, it burned itself out. And I think that's the best way.
Well, and the follow-up comment to that is the cure that worse than the disease? How do as a person in the medical profession, your job is to keep people safe and alive and healthy as possible. And I'm not saying that the medical community doesn't factor in what the unintended costs to society are in other areas, but it's like I said the other day on the radio. It's generals don't necessarily want to leave the battlefield because that's what they're born to do. They want to fight. So if I'm taking advice, I don't know if I take my full range of advice for them. So from the medical community's perspective, these harsh shutter all down kinds of things might provide the answer medically, but at what cost societally? And as you teach your students, I'm assuming you guys are doing online stuff now, aren't you, Doctor?
Yes. We've had to totally shift our education for our students to online. Thank God for online abilities.
And as you guys do that, are you able to incorporate lessons from this and talk to them about?
Oh, yes.
It's more than just the medicine side, but there is a price to society, and where is the crossover line, that sort of thing.
Well, I guess that to kind of throw this back is what's the cost of human life?
All right,
is being inconvenienced for a few days or a few weeks or a month to keep your loved ones healthy and alive. To me, that's a easy bargain.
Well,
society will bounce back. It always has from epidemics.
I understand that. If I have a grandfather who's 81, and that was one of the conversations on Tucker Carlson's program nationally last night. They had the lieutenant governor of Texas on, and he said, "I'll turn 70 next week. I don't, all these efforts in effect to save me, with no guarantees that it will, but that's our best guess at this point, as opposed to what the country will be like that my precious grandchildren inherit. Nobody asked me, but I'm ready to roll the dice." What about that sort of concept? If we on average say the people dying still while younger get sick, the people dying are 80 plus. So for a lifespan of another 3 years for somebody, we set the economy back 20 years. That kind of stuff enter the conversation in the medical world at all?
We have a much different perspective. Ethically, we're bound to do what's best to preserve health and preserve life. Again, if you have a teenager or somebody in their 20s or 30s who gets this and dies, that kind of goes against the logic. So we're not only protecting older people, we're protecting everyone in society.
Well, and I get that. So, I'm just trying to flesh out.
Who are at risk of death.
Just trying to flesh out a conversation. I mean, they're now what? Italy's no longer allowing people 60 and up ventilators because there's so few of them, and they've made a decision as to where the cutoff is on life-saving measures. How tough would that have been? I wonder. Those kind of triage moments where, sorry, Charlie, you don't get one of these. Best of good luck. That's got to be a tough moment as a doctor.
Those are. And, when we have adequate resources, we don't have to have those conversations. But again, if we do get to a crisis point where the system is being totally overwhelmed with critically ill people, you have to make those type of triage decisions. They're not easy, and they're not, they bother people who have to make those decisions, but you have to look at the greater good too.
Yeah, I imagine a whole separate branch of study is how to process making those kinds of tough calls and still going on.
Never have to go there, I suppose. Doctor, I guess a couple of last questions for you.
Sure.
I guess when this is over, when the quarantine is over, and we all come back together, do we risk having the virus start up again by coming back together again? And is this thing really going to ever be over for us?
Well, let me give you, I think that once the quarantine is over and the problem has passed, we're hoping, again, based on what we've seen in China, they've relaxed everything and they've not had any resurgence of cases. The thing about in the summer, winter time, illnesses such as influenza and that go away. It isn't so much because of the heat. It's mainly because people are outside and doing things and not in close contact. We know that the biggest risk factor is close contact with infected people. And obviously in the warm weather, as people go outside under normal conditions, the risk of that's a lot less. So we're hoping that with a period of quarantine, one way or another, that this will burn itself out.
Are we following the plan that China has or the plan that South Korea has? And if we're doing the one that China has, why aren't we doing the one that South Korea's got? Because they seem like they're making a lot of progress.
The other, one of the things in South Korea is that they have available testing and rapid turnaround testing. We do not have, the numbers that are being reported, I think with a lot of medical experts, at least in the United States, until we have available rapid testing, we're not really sure of the extent of it. But a lot of people guess that it's probably a lot greater than we realize. There are people who have mild symptoms. There are people who may not have symptoms but yet be carriers. How this occurs is you come in contact with a droplet or the virus. Within 2 to 14 days, you'll then start to have symptoms. But even before you have symptoms, you're shedding virus. So if you happen to sneeze because you have allergies or cough or whatever, you can have the virus go out and not even realize it.
Yeah,
that's the scary part.
Yeah, geez. All right, so if give us just quickly a list of the things that we're looking for in terms of how we're feeling. If we think we might have coronavirus, what would force me to want to get a test? What do you think? What are the circumstances that I would have to be under that you would think, oh, you better go get a test?
One of the problems with this is it's very nonspecific symptoms. It's not like your right ear turns yellow and falls off. The most common symptom, again, and this is coming out of not only the Chinese data but some of the other worldwide data, is fever. Fever, and it doesn't have to be a super high fever. It can be a low-grade fever, 99.5. That's the most common. The next most common is a dry cough, where you're just coughing like your throat's irritated. 33% of the people will have a cough where they're coughing up phlegm. Fatigue is seen in about 40% of the cases. Again, these are muscle aches, body aches. These are very nonspecific things. The time to get concerned is if you're running a high temperature. And I would say greater than 100, 100.5, associated with a cough and shortness of breath, where a person has to gasp in between words. Those are that's when it's time to get tested. This hits at varying rates. Again, some people have a mild illness, some people get it and ultimately die from this. So if you're having shortness of breath, seek medical attention. If you're having a fever greater than 100.5, at least contact your health professional or one of the facilities here for better guidance. Until we have drive-through testing where we can get instantaneous results, this is the best game in town. But again, the shortness of breath is really the key thing.
I was going to say phlegm, coughing, aches, vomiting. That sounds like Thursday at my house. Just on
I know.
An older DJ in action there. But all right, so
too much time at the bar.
That can do it too. So as you assess the Yakima Valley, Doctor, and by the way, we're talking with Dr. Mark Baldwin from our great teaching university there in Terrace Heights. Sir, how would you assess Yakima? How you think we're doing in terms of what you see from social distancing and what you hear from your colleagues and all of that? Are we hanging in?
I think we're doing well. We're I think it was Hiram Johnson who once said, "Truth is the first casualty in war," and it kind of has seemed to be this here. And there are a number of websites through National Institutes of Health, CDC, the Washington Department of Health, and even our own Yakima Health Department that can give you good fact-based information on this. And again, the simple things. What's the big deal about washing our hands? Well, we know that soap dissolves the coating around a virus. And you don't have to buy a fancy antibacterial soap, good old-fashioned soap, be it dish soap or whatever. If you wash for 20 seconds, that will dissolve a good portion of the bacteria or viruses. So, again, the simple things.
Interesting. Good old soap.
Yep.
Man.
Just like our mom said.
I was going to say, think how much I lost by having my mouth washed out so many times. I mean, I would have built up some kind of immunity from my youth, doctor, but okay.
Yeah, you know,
I know.
We hear all this stuff. Oh, don't use antibacterial because we're going to get immune to it and everything. Are we risking that now?
You can. I mean, not with the coronavirus,
Yeah,
I don't
okay,
think.
good.
But again, the simple things, just good old-fashioned soap and water, covering your mouth if you cough, keeping your distance, just like, the simple things always work the best.
Are you? Give us an example of you going to the grocery store. I mean, are you touching the door when you walk in?
I can see it now. There's the doc walking into a neighborhood store. What happens next?
Yeah. A lot of the stores have wipes of some kind, which are very helpful. I think that is really being socially responsible. I utilize those when I go to the store, and just simple things.
Yeah, well, just like you said, covering your cough, stuff like that. Masks. Right. What about masks?
If they're available, although they are not 101% protection, if you have them, they're better than nothing. We know that in people who are infected, it will decrease in wearing a mask. That will decrease the transmission rate from the coronavirus. But again, wearing a mask is better than not having a mask. So, and even some type of covering over the face, you decrease the amount of particles that you're exposed to.
Those the ski mask from back in the day when I was a little short on cash, I could put those things to. Well, never mind. It's a whole other story, Doc.
Those may be too big. That may be those holes may be too big to stop.
Right. It's a lot of it's just good old common sense. Being respectful, and like I say, if my approach is I've got it, I don't want you to get it. How do I conduct myself when I have to be out and about? And I certainly don't go out and about unless I have to. And if everybody did that, we'd probably be. Flattening that curve and moving on from there. Mm-hmm. How do we know what's a win, Doctor? We see these big numbers, and then we always hear people comparing it to the swine flu, where we lost about 12,500 people from that specifically over the course of the year. How do we know what the target is that we're shooting at? What's a win? Just get through it, or what?
Once we, as we see new cases. The new case rate starting to decrease, and I would imagine it would start up here in the Washington area, since this is where the first cases were reported. As soon as our cases start dropping, I think that would be an indicator that maybe we're seeing the light at the end of the tunnel. Again, based on the China model and based on other models we've seen with other epidemics.
I'm wondering about the testing. I mean, we see that we have a number, I think 10 presumptive positive cases in Yakima, and we have, the rest are confirmed. Well, why is it taking so long to get these things confirmed like that? And why do we have to go through a process like that? Why can't we just test and come out negative or positive? What's going on there?
We don't have enough tests, so we have to ration who gets the test. If somebody has a cold and comes in and says, gee, I want to get tested for coronavirus. They're not running a fever. They otherwise feel okay. And we only have a couple tests. I would rather test somebody who is more seriously ill to see, do they have this or do they have something else? We can test for influenza. We can test for different types of pneumonia. And if those tests come back positive, then you have a high-risk person, then we would go ahead and test them. But again, because of the lack of available tests, we have to kind of go where we get the biggest bang for our buck as opposed to the worried well.
How long does it take to get these tests back?
In other countries, they're doing them fairly quickly. Here, there are different protocols. Depends on what region of the country you're in. They can do a swab and send it, and it gets processed at another facility. So I can't speak to specific ways we're doing it in each facility here in Yakima County. But until we come up with a better, quicker test, that's the world we live in, and which is maddening not only for the people, but it's also for the physicians and the healthcare providers.
Well, we keep hearing about these presumptive positive cases. So what's that? Is that a case that's been, tested by a private lab, and then that test hasn't been looked at by the state? Or what? Why is it a presumptive positive at that point?
That could be because they're not doing one of the tests that is one of the standards. And again, I would have to look at what test. I mean, and is the definition of presumptive positive, meaning they just meet all the clinical criteria? Again, what's the definition of presumptive positive? Yeah. If it's a positive test, it's a positive test.
Right. Yeah, that's what I don't understand. Okay.
Doctor, we could spend all day talking to you. This is just really, really interesting, but we'll let you go on this last question, and that is the takeaways from this. What should we learn as a result of this that can help us the next time something comes down the pike? I mean, we can't have a respirator for everybody sitting in a warehouse somewhere. At least I don't think we can, storage and financially and all of that. What's the big lessons that we should take away from this for the future?
That, we still have, epidemics are still there. Mother Nature is still always rearing her head and letting us know who's in charge here. And again, simple things pay the biggest dividends. Hand washing, social distancing for a while.